Well, hello everyone, and welcome to the scientific abstract session of the 16th Annual International Conference on Stigma. My name is Vicki Haverman, and I'm the chair of the conference's scientific committee. We'll begin this afternoon by announcing the scientific abstract award winners. Afterwards, we'll hear brief oral presentations from the second place scientific abstract award winner and the third place scientific abstract award winner. So let's get started. The 18 posters that are presented on the conference portal were selected through a multi-round evaluation process by the scientific committee. From the fantastic research selected from this year's conference, the committee gave 3 awards. The Best Scientific Abstract Award went to Mr. Akena Nakawama for his research entitled Efficacy of Faith-Based Stigma Mitigation Intervention, 1-year outcomes from an implementation for religious leaders living with HIV in Nigeria. The second place scientific abstract award went out to Ms. Olivia Cordingley for her research entitled Parenting Medical Cannabis Patients Experiences of Stigma in Healthcare Settings. And lastly, the third place scientific abstract award goes to Ms. Farah Riazi for her research entitled Shifting Perspectives, Insights on Stigma from the New York City Health Department's Viral Hepatitis Program. So congratulations to all of our award winners. You will receive your prizes either in person on Thursday, November 20th, or in the mail after the conference. So now we're going to transition to our oral presentations, the most exciting part. The Best Scientific Abstract Award winner shared his work during the international session earlier today at 9:30 this morning. So please reach out to Akena Nakakama throughout the rest of the conference to discuss his innovative research in more depth. I'm sure he'd love to chat with you. The second place scientific abstract award winner and the third place scientific abstract award winner will graciously share their fascinating research with us during this session now. So it's with great pleasure that I introduce the second place scientific abstract award winner, Ms. Olivia Cordingley. Ms. Cordingley is a doctoral research fellow in the Department of Community Health and Prevention at Drexel University. Her background in social work is what informs her current research on the intersection of parental substance use, stigma, and child welfare systems. She's particularly interested in how Child Protective Services reporting impacts parental health and functioning. Prior to her PhD, Olivia worked with the Social Intervention Group at Columbia University to create community-informed interventions to promote HIV testing among women who exchange sex and use substances, and as a social worker at Henry Street Settlement in New York City, supporting families experiencing homelessness. So please join me in welcoming Ms. Olivia Cordingley.
Hi, everyone. Thank you so much for coming to this presentation. I'm going to share my screen. Oh, sorry. Let me give 1 second. Should have had this figured out. Okay. Sorry, can everyone see?
Yes, we can see it.
Okay, but probably not like full screen, right? Or
If you select view, I think it'll give you the option to do full screen or put it in slideshow mode, either one.
yeah, I'm trying to do slideshow for some reason. Maybe this is, I don't want to do that, right? Okay, I thought I had this figured out. I'm sorry. Um, okay. Okay, sorry about that. Can everyone see
Yep, it's good to go.
right now? Okay, great. Yes, hello everyone. Thank you so much for being here, and thank you to the International Stigma Conference for the second place award. I'm very honored, and my co-authors and I are all very honored by this. So thank you. My presentation is Parenting Medical Cannabis Patients' Experiences of Stigma in Healthcare Settings. And I'm at Drexel University. I work at on projects at the Medical Cannabis Research Center, and here are the names of some of my colleagues there that have been working with me on this project. I also wanted to share some photos of me and my team. Dr. Elizabeth Valdez is the PI on this, and I am her student and presenting this work on behalf of all of us. And then Sam and Emily are also my colleagues and helped me in interviewing patients and analyzing the data. So this is a really text-heavy slide. I'm sorry about that. Obviously, I have a lot of information. I'm very interested in this, so I'll just kind of briefly paraphrase some of this background. But as many of you know, there's many states in the US now that have medical cannabis programs and millions of adults who use medical cannabis to manage chronic health conditions. However, it is still a Schedule I drug, so it's deemed to have no medical value by the DEA. And this uh, adds to its stigmatized state. It's a highly stigmatized substance, specifically among parents who face like historic scrutiny for any drug use, and a little bit of, sorry, I think someone is not muted, by the way. I think a little bit of like policy background. The 1937 Marijuana Tax Act removed cannabis from U.S. pharmacopoeia, and so it was not used in medical treatment like legally until 1996. And a little more on kind of stigma that I'm bringing into this presentation is Goffman's work posits that stigmatized persons must carefully manage information about themselves to manage others' perceptions of them, and also Tanya Potiat's work from 2013 with transgender folks in working with medical providers and created the grounded theory around how stigma functions to reinforce like medical power and authority. And I'll get more into that. And yeah, a lot of the research that American healthcare providers don't really have a lot of knowledge on medical cannabis and holds a lot of biases towards cannabis, specifically for pregnant and parenting individuals. And there's just not a lot of research on pregnant and parenting folks using medical cannabis, despite it being a state-sanctioned substance. So this study, this is part of a larger study that was generally looking at what parents' needs and barriers are to using medical cannabis in Pennsylvania, who are patients. And as I was conducting these interviews as part of this pilot study, stigma kept coming up without us probing for it, and parents felt like this was the major barrier to accessing medical cannabis for them. So I conducted an independent analysis with the data to look more specifically at how mothers experienced stigma related to their medical cannabis use. So we conducted 48 in-depth, semi-structured interviews in 2024 with cisgender women. They had to be currently parenting children under the age of 18, reside in Pennsylvania, and have an active card. And they didn't necessarily have to be bio parents. We have a lot of like non-traditional parents serving in like non-traditional roles as well, and quite a variety of ages. And we used an interpretivist paradigm to understand these experiences of stigma from like subjective perspectives. We didn't pull in like stigma theory or any external theories into the the collection of data or the conceptualizing of this project, pulled it into the analysis later. And we created a code book based off our interview guide, and then refined our parent and child codes iteratively. And then me and my other graduate research assistants on this project double coded and engaged in intercoded reliability uh, to get trustworthiness, and then coded the rest of the transcripts in vivo, and did a lot of memoing to document emerging codes, reflections, our own assumptions and biases around cannabis use and motherhood, and yeah, prioritize these kind of emergent themes and emergent codes instead of applying a predefined framework. And then we organized all these codes and quotes into a matrix to identify patterns across the data. Here are my demographic results. So the majority of our participants identified as white, followed by Black, African American, Hispanic, Latino, and then non-Hispanic multiracial. And these do match the demographics of Pennsylvania, and also our larger cohort of folks in the registry. We had a mean age of 42. Average income was between $25,000 and $50,000. And the majority of participants had anxiety disorders as their qualifying chronic conditions. And then these individual qualifying diagnoses, or one person each, had these conditions. Nope. So our first key theme that we arrived at is that parents consistently described healthcare providers as lacking knowledge around cannabis, and some felt like they had to educate their providers about cannabis to treat their chronic conditions. And this is a long quote, but I feel like it was really integral to the analysis and the paper I'm working on, where this parent talks about how she tells her provider that she uses cannabis, but they still won't talk to her about it. She feels like she's kind of up against a brick wall. And she's sort of managing this program on her own. And it's a real breakdown in communication between her and her provider. She needs to see him for her chronic pain diagnoses, but they never talk about cannabis. And she has this quote here of if I do marijuana, I don't take this med, and then I don't take this med, So she feels like she has to take care of this on her own, and kind of take over the place of being a provider, and saying, okay, well, if I use medical cannabis, I can't take this other drug, and has to figure out the interactions on her own because her provider, for some reason, will not help her with this. But this reason, we think, being stigma, as she touches on stigma, like I said, that's certainly part of it. And yeah, just this breakdown in communication, and feeling like she's on her own here. Our second theme was that many parents anticipated stigma in healthcare settings, and so they decided not to tell their providers that they were using medical cannabis. This first parent says specifically, I think it stigmatizes me, and that she'll be tagged as an addict, and assigned this label of a drug user if she tells her provider she's using medical cannabis, even though it's a state sanctioned substance that another provider had to sign off on her diagnoses for her to use. This other patient and parent speaks about how she doesn't disclose medical cannabis use to her provider because she also has a medical diagnosis that's quite controversial among medical providers, and so she doesn't want to be doubly stigmatized. Her doctors already don't really feel like she has this disability that she is diagnosed with, and so she will like you know, says she'll lie to her. Like I said, I told them like I don't use medical cannabis. I don't have the card. Um, and talks about like I feel like this like lack of trust and like medical mistrust of I don't think my provider will handle this information well and it will impact the treatment of my diagnoses. So I'm just not going to tell them this. And this anticipation of stigma in the healthcare setting. Um, and yes, like a lack of trust in healthcare settings. And our third and final theme was that when cannabis use was disclosed, say like intentionally or inadvertently, they felt judged by their providers, and some feared social and legal repercussions. We say intentionally or inadvertently, as some parents had drug screening and medical cannabis was disclosed that way without them wanting to know, and then other parents like just told providers and then sort of had a stigmatizing experience and decided not to tell like other providers about their medical cannabis use. Um, in this first quote, this parent talks about this fear that's sort of in the back of her head, like they're going to call social services on me. Um, and they're going to come like meddling to my life. And this is like a very pervasive theme in our data of like a lot of parents saying, oh, it's always in the back of my head that, despite this state sanctioned use, like social services is going to get involved at some point, and I'm not protected as a parent. Despite having the medical card, I feel like it's going to initiate a process of state surveillance, then they're going to be meddling in my life. And then this other quote, um, this parent talking about when cannabis was discovered in her system, she felt like it opened up this line of biased questioning from her provider about whether she does other drugs, what kind of drugs does she do, and feeling like this was like a biased line of questioning and put up her defenses. And I think this speaks to like systematic biases against Black mothers, specifically around like assumptions of drug use and irresponsibility. And this leads to like medical mistrust. And yeah, she feels like she has to kind of put up this wall of like, well, maybe it's his job, maybe not. Maybe this is just his bias. Even though it is medical marijuana, it's very presumptuous of this provider to assume I'm doing other drugs because I'm using this substance to treat my chronic condition, and kind of opens up parents to these like social and legal vulnerabilities, and potentially like punitive actions on the side of um, medical providers. Um, so I've been working on this conceptual model to understand like the stigma and how it's impacting parents in medical spaces, and um, how this like perceived how these like knowledge gaps and their attitudes are contributing to like anticipated stigma and enacted stigma, and then these are impacting parents' disclosure of their medical cannabis use, which and these are all leading to medical mistrust and like a kind of a breakdown between communication between parents and their providers, which is ultimately leading to a missed opportunity for their comprehensive care. Because when providers don't know anyone is using medical cannabis, there's potential like drug interactions or, other medical um, things going on that providers can't really speak to. Um, and yeah, these like this anticipated enacted stigma are like contributing to an environment where parents don't feel safe talking about medical cannabis, which is fostering like medical mistrust, hindering their open communication, and limiting like their quality of care. And so providers are really missing an opportunity to give integrated treatment. And I believe also like providers are kind of upholding this like power and authority by refusing to talk to parents about cannabis use, or like when they do talk about it, like stigmatizing parents for it. Um, and I think the next step should be providers really need to pursue like their own education around cannabis. As you know, it's not often in medical curriculum, medical schools. Um, and so a lot of parents said that their doctors didn't really know anything about like the actual strains or dosing considerations, and they had to learn all that on their own. And since it's such a rapidly evolving legal landscape, providers really need to be abreast of what's going on so that they can support their patients who are parents. Um, and future research should also really look into providers' biases towards parental medical cannabis use, or like cannabis use at all, and how they're going to interpret and like enact mandatory reporting, because there isn't really protocol in place since cannabis is still kind of new and like um, rapidly changing. Providers have a lot of power over what they deem like problematic cannabis use, and then can report parents, and then there's potential child welfare involvement. And so I think we need to be doing more research into this, to be able to reduce stigma and promote equitable care for anyone using cannabis, but specifically parents who are at risk of like state surveillance and state involvement. Um, Sorry, I feel like I went really fast. I was trying to make sure I had didn't go over time, and I think I did. But thank you very much. Here is the website for a research center and some of my social media contacts. Thank you all so much.
Thank you so much, Miss Cordingley. That was that was really fantastic. Really interesting work. And very engaging presentation. We appreciate you sharing with us. Um, Now I'm excited to introduce our third place scientific abstract award winner, Ms. Farah Riazi. Ms. Riazi holds a Master of Public Health in Epidemiology from New York University. Currently, she directs the healthcare practice facilitation at the viral hepatitis program within the New York City Department of Health and Mental Hygiene. In this role, Ms. Riazi closely collaborates with healthcare teams, particularly within substance use programs, to improve the accessibility and support of hepatitis care for people who use drugs, a community often facing stigma. Throughout her career, she has worked to enhance access to hepatitis C treatment for people who use drugs, ensure the availability of naloxone in hospitals and other settings, and utilize telehealth to expand patient outreach. So please join me in welcoming Ms. Farah Riazi.
Thank you so much. Can you see my screen?
Yes.
Excellent. So the name of our presentation is Shifting Perspectives Inside on a Stigma from New York City Health Department, the Viral Hepatitis Program. I want to start by saying thank you for giving this award. We're deeply humble. I'm only one of the persons that worked on this project, but I know that some of my colleagues that also worked in this project are here. So yeah. Oh. Sorry, I cannot advance my slides. Okay, I'm gonna stop sharing and reshare. Sorry about that. Okay, sorry about that. So approximately 314,300 people in New York City live with hepatitis B and or C. Asian and Pacific Islander populations have the highest hepatitis B, while Latino and Black people have the highest rates of hepatitis C. This is a graph just to explain where our program is located. So we are within the Bureau of Hepatitis, HIV, and STIs. And we're with them, they created the Racial Equity and Justice Initiative, for short, the RESG program, and I'm going to refer to them moving forward in the presentation like that. And then they created different stigma work collaboratives. So the viral hepatitis was one of the stigma work collaboratives work group, but there was also another one for HIV and STIs. So the rescue team was able to provide us with templates and tools to really do an assessment on different diseases. We specifically focus on hepatitis B and hepatitis C. And the initial assessment that they gave us was to create a primer. So the primer was divided in two different parts. The initial part was to have like a general information with a summary of the staff that is in our programs, our mission, the disease summary, and the priority populations. And we were able to create one primer for Hep B and another one for hepatitis C. The second component of this primer was to really have a deep dive in on our program trainings and our program resources and the programs that we also fund, to really understand their activities based on the 3 levels of stigma on the institutional, interpersonal, and internalized level. And with that, they also asked us to create additional glossaries and references just to make sure that it was very comprehensive, as some of the language needed additional, like maybe information, so that it was easy for others to really digest. And then the other thing that we did with this project was to really kind of like have a more broad vision, and really looked at the national strategies and how our program was really, again, in these different components, aligned with the national strategies, specifically for the 2021-2025 hepatitis B and hepatitis C plans, and the elimination viral goals for 2030, not only on the city, but also on the states. And when we did this exercise, we were also able to identify 7 gaps and 7 strategies to really address those gaps. So this is an example specifically on the second component of the primer. And again, we did one primer for hepatitis B and another one for hepatitis C. I'm not going to go through everything for time, but just want to highlight a few things for each of them. For example, for the hepatitis B primer, on the institutional level, we identified that there was a lack of cultural and linguistic response from providers. So we are committed to really combat these with anti-stigma strategies that are focused on trainings for staff that is clinical and non-clinical, and also that materials are culturally competent on hepatitis B materials. In the interpersonal level, we know that there is discriminatory attitudes from providers and community, and we are part of a coalition that is called the Hep Free NYC, that has different programs and organizations across the city that meet quarterly and really share best practices, have presentations, etc. And it's a place to really become informed and understand what's going on in the community. We also have launched a New York City viral hepatitis elimination plan. And annually, we really put a report out on our surveillance data on hepatitis A, B, and C. In the internalized level, we know that there is fear of disclosure of the medical system from the patient level, and we have funded for many, many years the Check Hep B Patient Navigator program, which basically funds a patient navigator in different programs across the city to really be that bridge between the patient and the provider and provide that support that help them navigate the system. And specifically for hepatitis C, and again, in this component that is looking at the second part of the primer, we were able to identify that there is discrimination from healthcare for people who use drugs. And really, we are committed to have trainings that are harm reduction and trauma informed. We also have a hepatitis C toolkit that it's out, and really advocacy to reduce barriers. We also know that in the interpersonal level of a stigma, there is judgment language from providers. So again, all our trainings, even our RFPs, have embedded these and really come up with language that we know that is non-stigmatizing, including our trainings and materials as well. And the same for the internalized that we know that there is this emotional burden from cultural and family stigma. And we also have a hepatitis C patient navigator and a peer navigator with people with lived experience that really are able to provide, again, that support that patients need to navigate the system and not only access services, but go all the way to cure them, specifically for hepatitis C. And then as we were mentioning on the, on the assessment of understanding what are the gaps and some of the strategies, we identified that there is a lack of stigma resources. So we're committed to really create linguistic and cultural competent stigma-free materials. We also identify the need to have available a rapid diagnostic testing for hepatitis B. So we are advocating for the US to approve the global use of hepatitis B rapid diagnosed testing that will be helpful not only for hepatitis B, but also for hepatitis C, especially in the line of point of care testing that it's available for HCV RNA. We know that there is limited routine screening for hepatitis B and C. So really thinking about how to support programs, again, RFPs or any of the work that we do for that screening and care to happen in non-traditional settings, as we know that patients may not be going to clinics and hospitals. So really rethinking those models. And in the same sense, on hepatitis B vaccination, really promoting mobile clinics so to expand that access for hepatitis B vaccination. The other gap that we identify was that there is gaps on hepatitis, gaps in harm reduction strategies for hepatitis C. So really, again, integrating models that really understand substance use and treatment at the same time, including, for example, introducing telemedicine as an option to improve on care and access. There is insufficient, as I mentioned before, provider education. So really developing culturally relevant hepatitis training with CME credits it's very important. And lastly, restricting access to affordable care for unsure populations. So expanding a state level patient assistance programs is fundamental. So in conclusion, the BHS Stigma Work Group Collaborate has promoted really this syndemic approach. And what we mean over here is that not only this deep dive in within our own programs was very important, but we were also able to understand in these different stigma groups, subgroups, for example, the intersectionality between HIV, hepatitis, and STI, and have been able to collaborate, putting webinars out within our own bureau. So it has been super helpful. And specifically for the viral hepatitis program, we have been able, again, to identify key barriers to prevent, care, treatment, and really committed to reduce the stigma across the 3 stigma domains in our programming as well. Some of the limitations of these is that this is a self-assessment. So we may not have, we may not we may be limited in objectivity or hidden their external validation of findings. The equity consideration is that this work has been fundamental for us to really not only do a self-assessment, to really think about the future and how to really address race, immigration-related, socioeconomic prioritization of communities disproportionately affected and impacted by not only drug use, but also structural racism and limited access to care. And we're really committed that our materials and trainings have those components of linguistic and culturally appropriateness. So what's ahead? We plan to implement these internally and external trainings within our own agency and Department of Health with different bureaus, so they understand the hepatitis stigma with all the work that has been done. We really are focused on advocating to expand access to rapid hepatitis B testing once federally approved, enhance community-informed stigma by utilizing measures in program design, especially among unrepresented populations, and really advance policy advocacy to dismantle systematic stigma and improve access to hepatitis care. I want to acknowledge my co-authors, Reed, Pharma, Julia, Ernest, Marie, and Diana, that had been fundamental for this work to go forward, and also some of all the viral hepatitis team that provided feedback and contributions, our programs that had been able to provide feedback, and the Reggie team that really had been fundamental to guide us through these efforts. Thank you.
Thank you, Ms. Riazzi, for sharing your very important and interesting research. We appreciate it. So we've now reached the end of the Scientific Abstract Prize winner presentation portion of our session. Just as a reminder, you can access all of the poster presentations on the conference portal. So I'll now turn things over to Patty Houston to announce the art award winners. Take care, everyone, and enjoy the rest of the conference.
Hi, everyone. Sorry for the delay. Had to get myself into the session. Hold on one second. Okay, for those of you who I did not see yesterday, my name is Patty Houston, and I am a project director in the Department of Pediatrics at Howard University. At this time, I would like to thank all our scientific abstract winners for their presentations, as well as getting ready to announce the winners of our annual art contest. So this art contest submissions span many art forms, including drawings, paintings, collages, poetry, short stories, music, and videos. I'm going to show you the slideshow now, and then I have a couple more announcements after that. The winners will all be receiving a gift card prize. Hold on one second. Let me share. Okay. Whoop. Okay. Hopefully you can see my screen. Okay, so this year, as we did last year, we actually had, well, this year we had 3 categories. We had first our Empower category, which stems out of a grant that we have, which involves HIV prevention in Black women. So they had a separate category for art, either by Black women or about Black women as like the subject of the art. Third prize in this category, we had this painting called Stop the Stigma by Janice Shante Morin. This was a school age participant from Texas, from a group that submitted a lot of artwork that they did for another HIV related project. So we want to congratulate her. Unfortunately, I don't have her exact age. I believe she's a high school student, either that or possibly recently graduated. Second place was a poem. We did post our written artwork on the web page, on the Whova page. If you click under resources and then documents, you should be able to see all the written submissions from the contest. But this was a submission from Uganda. So I'll just read a quick excerpt from the poem. Mental health is not madness, not shame, not sin. It's the battlefield inside where healing begins. To seek help is power, to speak is to reign, to rise from the ashes is to break every chain. So again, the whole poem can be found on Who Can You Tell, as well as on it'll be on Who Can You Tell later. Right now you can find it on the Whova website. First place was actually a collaborative painting by two artists, Duji, the artist, Charmant, and Sarah Condera. And this was entitled Innocence Within Chaos. And if you can see, you could also turn the painting upside down and there will be like the opposite scene. So congratulations to those top prize winners in that category. We also had a few honorable mentions. We have a poem by Ikena, who was actually one of our speakers in the international session, Ikena Nwakama. So this was Elegy for a Withered Blossom. So again, I'll read a couple lines for you. Let your laughter return like a rain song. Let the world hear your melody. Elo, blossom again, even the desert bows to a stubborn flow. So you have to log on to read the whole poem to get the context there. That was, I believe, the ending of the poem. And then we had another kind of like an essay from Miriam Whitehead, being stigmatized and ostracized through my eyes, seeing what I have seen, being labeled as dirty and irresponsible. Uh-oh, we're going the wrong way. Go back. Is it possible to be hopeful in a world that constantly throws stones? Go back into presentation. Sorry. I don't know why it skipped ahead. Okay, our next honorable mention is a drawing called Be Aware and Be Prepared by Elizabeth Canales. This was another school age participant from the group in Texas. Okay, then we had another separate category for artificial intelligence assisted art, because we wanted to make sure that was kind of a separate category. We just gave one prize in that category this year because it was a smaller category. So this was Blood Ties by Hermione Johnson. And that's a very beautiful AI assisted artwork there. So congratulations to her. And now in our general category of art, which was open to all types of art, third place was a poem labeled by Marcella Zimmerman. I'll again read just the end of it. The label isn't my flaw, it's your failure to look past it. Because real beauty isn't branded, it's lived, it's earned, and baby, I wear mine boldly every damn day. So thank you to Marcella, who is well known to our group because she participated in another initiative we had over the last couple of years. Second prize was this painting, Mind Bondage by Teddy Reed. Actually, if anybody knows Teddy, reach out to me because we have not heard back from Teddy and we want to make sure that they receive their prize. First prize, We Can Overcome by Aziz Mohammed. And honorable mentions, we have yet another participant from Texas. Let's Stop HIV Together by Cassidy Howard. And then we have a video called Alone by Sean Driscoll. And this video is going to play right now, actually, during our lunch. It should be one of the videos that cycles through, and it will also be linked on our website later. And another video, The Storm by Ayanna Johnson. The same thing. This is going to play in just a few minutes. We're going to have different videos at lunch. Okay, and that's back to the beginning. So congratulations to all our art winners. It's one of my favorite parts of the conference is receiving this art and being able to share it with everybody. Okay, let me just grab my notes in case I forgot anything. So as I said, during lunch, we're going to be sharing a longer reel of the stigma stories. You'll see some of the same ones you saw before, as well as some other ones. And then we're going to see the different artwork and different videos during lunchtime. Also take a little time for yourself. It's just a 45-minute break for lunch. So our sessions will start again at 1:45 with a sickle cell mental health session. And then we have some other sessions this afternoon and ending with our 4:30 to 6 autism recognition and response. So you heard about autism this morning, but this is going to be a really in-depth, more of like a training about autism. So we will also offer a certificate of attendance to anybody who attends this training this evening. Just remember, fill our surveys and evaluations, go on our community board, other resources in Whova, interact with other conference attendees, and make the most out of these few days. Hopefully we'll see a lot of you tomorrow in person. If you cannot join in person, definitely log on online again. I'm going to hand it over right now. Hopefully Ashley's joined the session as well, and she's going to do our second raffle. Thank you, Ashley.
Hello. Yes, I'm right over here.
Are you right there?
Yeah, thank you everyone for joining. My name is Ashley Danto. I'm a project assistant on the Empower Project within the Department of Pediatrics and Child Health at Howard University. And I'm going to announce our second raffle winner for a $50 Amazon gift card. And the winner is Henrice Roberts. I'm not too sure if she's on right now, but we will be sending you that gift card in the mail. So thank you so much for participating, everyone.
And I was just reminded by Joanne that I neglected to mention, in addition to all the art content at lunch, we do have our third and final poster session. So please look over the posters, attend, if not all three of them, at least pick your one or two favorites and attend those, and maybe catch some of the art before or after. So that we hope to see you on all the sessions. Thank you and enjoy your lunch. Bye, everyone.